Namrata, for having me here. We're all going to talk about the central topography, the new upgrade on IOL Master 700. As Rajesh was telling, several ophthalmologists think what is the big advantage in having an optical biometer? You can get very good results with just the A scan. I actually, in one way, accept that because I can do a brilliant A scan. When I travel and I come back to work, one of the things that worries me if A scan done by somebody else. But after the IOL Master 700 came in, penetration is better. That becomes very less. But to get that accuracy with the A scan is extremely difficult. And we are trying to get within 0.25 to zero point 0.5. I just had a patient a couple of days back who was very unhappy having had a multifocal done elsewhere, perfectly done surgery, and he's unhappy that he can't see both distance and near. He has a 0.75 with a 0.5 cylinder, and he's extremely unhappy. So if we're trying to get that kind of accuracy, yes, we need to get into optical biometry. And you need an optical biometer or the technology which can go through dense cataracts very efficiently and give you accurate results. So there are two things there. Optical biometers have come to stay, and swept source biometry is the gold standard as of today. For several reasons. One, with a swept source, you get fantastic K readings, and you also get high penetration and accuracy in the axial length. A lot of times we kind of take for granted the keratometric values, and we really don't think that keratometric values have that much significance, and we are quite lax in recording that. We have to understand, it's better that we understand it faster, that accurate K values are as important, or if not, I would probably consider it to be more important than an accurate axial length. With axial length, you can be off by 0.1 or even 0.2, and you really may not get a big refractive surprise. The same amount of K value difference can give you a disastrous outcome, and a combination of both, a 0.1 or 0.2 off on your axial length, and also inaccurate both the axis as well as the keratometric values being slightly off. That's when you end up consistently with poor results and with these multifocal lenses or trifocals. And we start blaming the technology or start blaming the multifocality or blaming multifocal lenses and put them down. No, any multifocal lens works, including the oldest lens in the armamentarium that we have. Yes, the newer ones work a little better, but the first thing is that the surgeon has to get the biometry on the dot. And then after that, we look at the appropriate formula to calculate. So that's already been covered, or a different person will cover that. So when IOL Master was launched, that was launched about almost 20 years ago, I bought one of the first ones in South India, and everybody was laughing. Those days, it wouldn't penetrate probably 40 to 50% of the cataracts, and then they were laughing as to why I bought it. I've gone through 4 IOL Masters till now, and I'm very happy with the 700 with the TK, which really made a big difference. And the CT, or the central topography, is definitely icing on the cake, and it's really worth it. So what did we get of the IOL Master? Swept source biometry made it much more accurate as far as the axial length and better penetration. And also the swept source made the K value, the total TK, a little more accurate than just getting it from the anterior and taking the corneal thickness and assuming the posterior curvature. Now you actually check on the posterior curvature using swept source, as well as anterior curvature using the telecentric keratometry. And when you marry both of these, you get a TK that is absolutely accurate. That did make a difference. And of course, the added integration of the Barrett suit made a huge difference to outcomes. So we have to accept that topography is an integral part of biometry. There's something, again, we all do it. We all look at the topography of all our patients. If not all patients who you're going to put in any kind of an advanced IOL, if it's going to be a toric IOL or it's going to be a multifocal IOL. Why would you want to look at topography? You first want to know if the topography is regular. In a highly irregular astigmatism, even putting in a toric lens may not give the result that you're looking for. You may burn your fingers. So you really want to know, is this astigmatism treatable either by LRI or by toric IOL? Are you going to be able to treat it to your satisfaction and the patient's satisfaction or not? Another important part of looking at the topography is to find out if there are high amounts of corneal aberrations, which are possible. You look at the aberrometry also. If you can have the eye trace, you know the corneal aberrations from the ray tracing, and that tells you when this person is going to be an ideal candidate for the high-end lenses, such as the bifocal, trifocal, or one of the EDOF lenses, or the newer ones that we're seeing now, the hybrid lenses. So topography has been accepted as something that we have to do. So in your workflow, you have to do biometry. We know that it's one station, you can get the keratometry as the axial length, and you can also do the calculations. But we need to go to another station, look at the topography individually, look at that, and come to a conclusion as to whether the person is suitable for certain kinds of lenses, or is he going to get an excellent outcome, or the outcome is going to be questionable. So topography had been done separately. Now you have the integration on the platform where you get the central 4 to 5 millimeters, which is good enough for the surgeon to decide whether this person, you can just go ahead with putting in the lens of choice, or this topography needs further evaluation, and you would like to put this person on a more advanced topographer to study the cornea before you come to the conclusion as to what kind of a lens you're going to put in the patient's eye. The topography, the central topography, is not going to tell you that you're not going to give you any further accuracy in your IOL power calculations. But it does give you at one station, which takes, as I go along, it just takes about 45 seconds to do both eyes. So your workflow is much faster. Your decision making is more precise. You don't have to put everybody on a total topography. That takes a bit of time. And if you have an uncooperative patient, that really makes the day difficult for your optometrist and your team. And also you'll be waiting for the patient to come back. So it does help if the integrated topography is present there. So regardless of the type of IOL, you would love to know the topography, but particularly if you're looking at toric IOLs or multifocal IOLs, topography is very, very important. So this looks at the topographic diameter maximum of around 4 to 4.8 millimeters. It's almost 5, which is good enough. So this is the picture that you would get on the 5 millimeter zone, which gives you a look at the anterior and the posterior. It takes only 45 seconds for both eyes, where you would get the biometry, total keratometry, and the central topography. It's not that you're spending time taking each of these readings separately. At one go, all of these are through. And you can get a nice printout, or you can have it transferred on forum to your desktop, and you can evaluate it very accurately and swiftly. Total keratometry, I like to just go back and look at it, though this has been available for quite some time. It's really important, where you're looking at the anterior curvature very accurately with the telecentric reading that you get from the IOL Master 700. Then you have the swept source evaluation, which can give you the posterior curvature very accurately, as well as the corneal thickness. Today, actually, I prefer to look at the corneal thickness from the IOL Master as the gold standard for deciding even my refractive patients. I don't go by the, I actually don't go by the IOL, the ones that you get from the topographer, Streamflux. I find this to be even more accurate than that. So you have the anterior surface curvature, then the axial map of the anterior, as well as the posterior curvature comes in, and you get a real refractive or a true K, which gives you an enormous advantage in your calculation. So that's part of the TK. So how do we use the CT, or the central topography? It's very intuitive. It's just like all the color coding is the standard. The red is steep and the blue is flat. So it's still intuitive. So this is how you would see on the left side of the screen, what you would see a central steepening. If it's normal, this will appear, and a flat, that is post LASIK or a post any other treatment that's been done on the cornea, a myopic treatment or a very flat cornea, it'll come out blue. Once again, this is intuitively, whenever the eye is, the cornea is very flat or very steep, intuitively this machine would realign the color coding to make it intuitively understandable. So you know that you have an area that is steeper or flatter, and the color coding is intuitively realigned by the machine in case the keratometric values on the steepness is very high, or the flatness is very low, it's very, very flat. So let's look at a few cases, then we'll come to a couple of cases that I have applied it on and got fantastic results. So if you are looking at regular astigmatism, either with a rule or against the rule. If you look on the left-hand side, you'll see what you get from the IOL Master 700 on the 4 millimeter. But if you have a Galili or G4, how the 4 millimeter zone will appear on the same patient. So if you compare both, they're highly comparable. And let's look at the 9 millimeter. You really are not getting any extra information by going for the 9 millimeter zone than what you get out of the 4 or 5 millimeter zone of the IOL Master 700, where the astigmatism is regular. So it lets you know the astigmatism is regular. Please go ahead. You can do this case. Either you can put a toric in, or you try an LRI, or you want to go ahead with a non-toric lens. Or since it's a regular cornea, you can plan to put on a multifocal if you choose to. So against the rule will appear this way. Again, the central part in the Galili, you don't really get any greater information on the 9 millimeter zone than you would get on the 4.5 or 5 millimeter zone that you get standard on the IOL Master 700. So this would put it into perspective that in a regular with the rule or against the rule astigmatism, when you're planning any kind of a surgery, a cataract surgery, with any kind of an implant, a monofocal, a multifocal, or toric lens, your decision-making is over at this point. You really are not going to need the patient to shift to another station and undergo another examination. Your results here are highly reliable, and they are good enough for you to proceed with your next step of surgical planning. When we look at something that's more peripheral, now you look at the case of pillosid marginal degeneration. The central 5 gives you quite a regular astigmatism. But if you were to look at the 9 millimeter zone, it lets you know that there is something going wrong at the periphery. But the decision making here as to whether you're going to put in a toric lens, or you're going to put in a monofocal, or you're going to put in a non-toric lens, can be made with the information that you have on the 5 millimeter zone. But probably you'd like to see the look at the periphery to make sure that it's a non-progressive disorder to make a decision. But as far as the choice of lens is concerned, the choice of the type of lens is concerned, the 5 millimeter zone central topography is good enough. Let's go to irregular pathological astigmatism. This is where intuitively lets you know something is going wrong. So you can have a look here at an early keratoconus, where it lets you know right away with the color coding itself that there is something wrong. The superior to inferior, there is marked inferior steepening, which is noticeable at the 5 millimeter zone itself. The Galili also gives you the same information, nothing more on the 4 or 5 millimeter zone. When you go on to the 8 or 9 millimeter zone, you have definitely far more information that tells you that this patient probably has formiflustic keratoconus or a full-blown keratoconus. So what again you gain here is that with the single-step evaluation, you are already being warned that there's something wrong in the 5 millimeter zone. So this person needs to be evaluated further before you take any decision on the type of IOL that you can put in. So when you come to so far you're looking at the Galili, if you're doing a dual shame plug, like both a machine that uses a shame plug with looking at the anterior and posterior, are we going to get any more data than you will get on the 5 millimeter zone? On irregular astigmatism, straight away the 5 millimeter zone picture tells you that you have a skewed astigmatism here. So this person is not going to benefit very much from a toric IOL. Either you still go ahead with the toric IOL knowing that it's going to get undercorrected or overcorrected, and both the surgeon and the patient is aware of it. So the decision making is over here itself. But if you wish to go look at the cornea, the 9 millimeter zone, in this simple irregular astigmatism, there's nothing more that you have found out to make your decision by going to the 9 millimeter zone. Post-penetrating keratoplasty, again, you know this patient is a post-keratoplasty patient. You get this kind of a picture, which tells you, yes, you can go ahead and even put in a toric IOL in this patient, because it's fairly regular astigmatism. It is not too skewed, maybe slightly, maybe about 5 to 6 degrees. This patient would still get a very good outcome even with a toric IOL. Going to the 9mm zone doesn't really give you any further advantage, but one can look at that. So, but you do get the information that there's something more here. The decision making can be made at this point, or you can go and evaluate further. On a Scheimpflug device, we look at the comparison between these 5mm zone in the IOL master to a 4mm zone in the pentacam to a 9mm zone. Now you look at that, the information is no more accurate in the Scheimpflug than you would get with the Cept source technology on the IOL Master 700. So here, with this amount of information, you can still proceed on to making your choices of lenses or the kind of lens you're going to put in toric or multifocal. In a pellucid marginal degeneration, again here, the 5mm zone itself gives you an indication that something is going wrong at this point. And when that is seen on the 4mm on the Sirius, it gives you the same amount of information. Of course, on the 9mm zone, the diagnosis is made. So here, the compatibility is still very good, even on a peripheral corneal disease. The red markers are thrown up even at the 5mm zone or a 4.5mm zone when you use the IOL Master 700, which helps you make your decisions quite accurately. What about irregular astigmatism or irregular corneas post laser vision correction? Again, the central 5mm is the most important. You have all the information you need from there itself, that you can proceed without even looking at the peripheral values. But if you wish to look at it, fine. This again is another central flat cornea. The amount of information that you get here that the ablation has been decentered is well noticed at the 5mm zone itself. So you have the information that you need to make your decision even with this picture. But of course, you study it further, you find out it's a really decentered ablation. Hyperopic, it very well throws up a central steepening, but you really don't catch the peripheral flattening unless you're looking at the 9mm zone. The central steepening is very well noticed. So then with a history of hyperopic treatment, you will know what you're handling. If you're in doubt, of course, it's better off making this out so you know exactly what you're dealing with. So this is one where it is again slightly decentered, which is again very easily caught in the 5mm zone itself. So to look at reproducibility, when you're doing measurements 1, 2, and 3 on the same patient on the IOL Master 700, you get consistent results comparable to another patient. Again, comparable to two patients, 2 eyes. The 3 measurements are highly comparable, so reproducibility is very good. Compare that with the Pentacam and the IOL Master, top and bottom. They're highly comparable again. So the accuracy of this instrument compares with a Scheimpflug device and gives you very, very accurate and comparable results. So we'll come to a couple of my patients. This is a person for whom about 18 or 19 years ago, I've done a toric ICL after doing collagen cross-linking for a person who had keratoconus that was well controlled. So you'd find here that the astigmatism is fairly regular. It's not a very irregular astigmatism. It's the cone is quite central, and you can expect this person to get quite good results. You can actually see the ICL in place. You can see it there, and then the cataract that's developing behind. The left eye shows a slightly decentered cone, but central enough for one to decide and go ahead with the placement of a toric multifocal lens. You can look at the K1 and K2 values, 50 and 46 in the left eye, and 52 and 47. K1 and K2, 47 and 52 in the right eye. So we went ahead, we did the calculations, and then we used 13.5 IOL with a 7-cylinder in the right eye, and 15.5 with a 4.5 cylinder in the left eye. We used Zeiss made to order trifocals, the toric trifocals. And this was the lens that was ordered. And this was the result we got. So we were bang on. Of course, the bang on was because of the calculations. Absolutely brilliantly came on perfect. But the choice of deciding to go ahead with the toric IOL was made just by looking at the 5 millimeter zone. Of course, I did do my topography to make sure that I understood it further because this was something pretty new to me. But we got the result bang on, and the patient is extremely happy with no problems whatsoever. The second is a post LASIK IOL in a person who's undergone laser vision correction 15, 20 years ago elsewhere. I have no record of anything at all whatsoever. You have a flat cornea and you have a very, very long eye. The cornea is about 47. In the right eye, the cylinder is only 0.5, and the left eye is about 1 cylinder. And here the patient was not willing for either LRI or a toric lens. And of course, I decided to go with a monofocal lens in this case. He also had myopic macular degeneration, so it's not an ideal candidate for any kind of multifocal lens. Axial length was very long, 32.54 in one eye and 32.38 in the other. So this is the central the CT, which showed fairly regular ablations, slightly maybe decentered. Of course, that's to be expected. This technology this person underwent many years ago, maybe 10, maybe 20 years ago. So that's what we can expect with that technology at that time. So postoperatively, of course, the vision was only 612 because of the macular degeneration, but the results were bang on again. The 0.5 cylinder that was pre-existing on the cornea in the right eye stayed at 0.5, while the refraction that we got in the left eye was 1.5, while the corneal cylinder was about 1. So again, the decisions to go ahead with the kind of lens that we decided here not to go in for a multifocal for 2 reasons: very flat cornea, and the number 2 was that, of course, the macular degeneration was present. So having the access to a central topography at ease, at one single step available to you right up front, does make your workflow more smooth, your work faster, your decision making is more precise, and you can always go back and work up patients who need further workup on a shame plug or any other kind of an instrument. But this one-step evaluation, which goes A to Z at this point of time, is definitely an advantage. Thank you.